Going to now hear from Dr. Gabby Cehic. So Dr. Gabrielle Cehic graduated from University of Adelaide in '89 with a Bachelor of Medicine and a Bachelor of Surgery. She then went on to complete fellowships in oncology and nuclear medicine. She's currently a staff specialist in nuclear medicine at the Flinders Medical Centre, the Queen Elizabeth and the Lyell McEwen Hospitals. She also works as a nuclear medicine physician for Radiology SA. Her interests include therapeutic nuclear medicine, especially focused on the management of thyroid disease, neuroendocrine tumours and other tumours expressing somatostatin receptors, as well as survivorship and quality of life. Her expertise is in targeted peptide receptor radionuclide therapy, or PRRT, for NETs. And Dr. Cehic established the statewide referral and therapy service for PRRT in 2009 and continues as coordinator of this service, which is based at the Queen Elizabeth. Since that time, PRRT has been provided to 115 patients with NETs, and the service has expanded to support an annual nuclear therapy fellow and a clinical research NET nurse. She is the inaugural and current chair of the monthly South Australian NeuroEndocrine Tumour Multidisciplinary Team meeting. She was a key member of the working party to develop the South Australian gastropancreatic, gee, these words are big, aren't they? Neuroendocrine tumour pathways in 2013, and this was facilitated by funding from the Unicorn Foundation. And like Tim, Gabby has just also joined the Clinical Oncology Society of Australia Neuroendocrine Tumour Special Interest Group Executive Committee. So because, you know, if you want something done, ask a really busy person. So look, I invite you to welcome Gabby to the stage. We're so grateful to have you to share your knowledge.
So I'll try and take on from where Tim left off. So you've had a general idea about the fact that you will all present differently. Some of you here are patients that I know, others are support people, and some of you may never have been to a NET presentation before. And I suppose the take-home message from the clinicians in the room and the support people are that you all will have a different story. If you go to an internet to look for supportive information, be it from the Unicorn or the Cancer Council, you won't find your name there because your story is not written, and you're going to write your story with us, and our job is to try and make sure that as every new treatment becomes available, we do our very best in this state to try and avail you of those opportunities. And I think that's the most important take-home message. We can see a really amazing evolution in what I think is a relatively short amount of time, from when we first started, from when the European group all got together in what we call ENETs, the European Neuroendocrine Tumour Group, who've been amazing and instrumental in getting guidelines out there. And guidelines are just that, they're meant to just help us make decisions. So I used to end with this slide, but I want to tell the story that we really want you to understand that each of you are really special, and our job here is to keep you on the beach or on your cruise ship or in the caravan travelling Australia. Okay. I put this up knowing that you probably would have had this as an initial slide, but at different points along your treatment journey, there will be times where you really don't feel well, and I want to just keep reflecting on the fact that whatever we do, whatever form of diagnostic scan you have, whatever treatment you have, is all about making you feel better. As Tim has already alluded to, there are different ways that you will be scanned, and I just put this up knowing that you probably would have had some initial information, but just to make the point that sometimes we pick lesions up incidentally because you're being scanned for another reason, or more and more for those of you that may be part of a familial kindred that have got known mutations, will actively go looking. And some of the new technologies around early endoscopic evaluation have meant that we're able to find tumours at an earlier stage. That's a very different pattern, and it may be relevant to some of you in the room. So we're not always dealing with advanced disease. I'll keep it really simple. The take-home message with this one was to say, yes, we have the so-called Hobart test. That's the test that you fast for. But more and more, we can look at other parameters, circulating tumour cells, and different molecular and biological ways to evaluate you. I just really want to give you a snapshot that each one of these areas, be it the standard CAT scan, be it blood tests or histological tests, have all got new advances, and there's a lot on the horizon. I'm often getting asked, I'm sure Tim does as well, what about the fact that they could take a blood sample and tell if I've got blood tumour cells before there's anything visible on a CAT scan? What about the fact that if they put a snake or an endoscope down, they should be able to find my pancreatic tumour at a very young stage? So there's all of these new advances. But when you do get to that point where a piece of tissue is taken, I've put this slide up because one of the areas that I know we bamboozle you with is we'll use for the same terminology, we'll use a different word. We might say a tumour or a mass or a cancer or a carcinoma or a neoplasm, and all of those can be graded and put together in a different manner. And over the years, we've really had a change in the way we talk about this. So collectively, they're all called neuroendocrine tumours or NETs, or if we want to be really expansive, they might be called JEP-NETs. And that also reflects the different part of the body, gastro being stomach, entero bowel and pancreatic, hence JEP-NETs. We've got JEP-NETs, we've got NETs, we've got neoplasms, we've got tumours, we've got masses. I'm not surprised that a lot of you end up being confused. So I just wanted to touch on that. And I also wanted to touch on the fact that we as a community know that we can continue to define these diseases differently. And I think a lot of the work in the area of imaging, functional imaging, PET, has told us that within any one body, the tumour may be different in different parts. And that's why sometimes you might be asked to go back and have a different biopsy, because your scans suggest that maybe the pattern of your disease is not the same throughout the body. When we look at the evolution of imaging, I know some of you in this room have had your disease, your tumour, for a long time. And I suspect that for some of you in the early days, you may have had the first generation of functional imaging scan called an octreotide scan. We've come along, I've got a couple of nods in the room. We've come a long way from that time. The point about this one is to say that regardless of what tracer we use, we are always looking at a way to target the tracer to a receptor that enables us to say, yep, we know that your particular tumour has a particular characteristic. What we do know is that this is scarier than that, although it's actually in the same patient. So sometimes we just see more. And the scary thing about this is sometimes you think, well, if I've got that much disease, does that mean that I've really got a very serious condition? And yes, it might be serious, but just because we see more, it doesn't necessarily mean that we can't stabilise your disease. And one of the things that is quite confronting when people come for treatment is to see these sorts of pictures. Even since the last NET forum, we've come a long way with funding, and one of the areas we now have funding in is around the GAT8 PET or the dotatate PET scans. We're lucky in South Australia because within the public hospital system, within the Royal Adelaide Hospital with 2 cameras, generally you should be able to have your camera with no extra burden of cost. And I think also in the private arena, more and more of them are happy to bulk bill. Well, they'll certainly be happy, and if you fit into this category of wording, hopefully at least once a year you should be able to have the gallium PET scan. But sometimes we might ask you to have one of these, that's the glucose PET. And unfortunately, neuroendocrine doesn't fit into the classic group of tumours that the government is happy to reimburse. But watch this space. I'm hoping by the time we have the next NET forum with our wonderful advocates that maybe the glucose PET will also be funded. And if there's anyone in the room, I've always put this on, in fact I know there are in the room, so just to also put the point out that more and more, instead of using MIBG, which was the traditional way we scanned for the pheochromocytomas and the paragangliomas, which is another very sort of related group of diseases, we're now more and more using gallium. And again, that's a good thing because it's easier to get hold of. I'll keep this simple and I'll take you straight to the pictures for interest of time, and it is a complex scan, but I just want to make the point on this one. The reason we will often ask you to have both types of PET scan is we want to put them side by side, and it will tell the story of the disease in your body, and it will tell us what sort of treatment will be appropriate. Now, at the moment, we still are under the impression and the belief that if you've got a very low-grade tumour, you may not need to have the glucose PET. The caveat there is if we think your disease is low-grade from a biopsy from the liver, that may not tell the whole story, and it might be that that small sample that we took from your liver at that moment doesn't necessarily reflect the whole disease. So again, mindful of the financial burden. But when we put it all together, we're all about trying to make a snapshot in you at that moment in time so that we can then work out what appropriate treatments we can put into play. So when we talk about therapy, we've seen a similar slide, and Tim just showed this. So we know that we can target the receptor, and that's usually the first line of treatment for the majority of neuroendocrine tumours. So in the early days, if you had a lung neuroendocrine tumour, you weren't eligible for these injections. That's changing. Even with the pheochromocytomas and the paragangliomas, we need more evidence, but it doesn't really make sense because if you have the receptor, one would think that you should respond. Usually the second line treatment, again depending on your imaging, is the peptide receptor therapy, and I'll talk to you about that in a minute. Tim's also discussed teletristat, and I think given that it has a really good role in reducing serotonin not only can cause the flushing and the diarrhoea, but also long-term can have effect on those valve hearts that we talked about. So maybe in the next few years we might find that there's an increasing place for teletristat to help protect heart valves. We don't know yet. Interferon is not a big one here. I used to get asked about this all the time. I'm not sure if Tim did, because there's a lot of European and American literature about interferon because they didn't have access to luteate. And then there are other drugs I'm not going to touch on. You probably have heard the term Theranostics. So Theranostics is a term that we put together, which is really just, I've said, put together by a dyslexic individual. I'm sorry if anyone in the audience is dyslexic, because it's the opposite way around to which we would actually do it. So you've got the therapy following the diagnosis, but that would be hard to say ostnicther. So it's why it's Theranostics. And basically what we're trying to do is identify, does your tumour express the receptor that is sufficient for us to bind a radionuclide to? And thank you to Michael Hoffman and also to Marnie Nenke who have updated this, and I think it's a really good visual to show you that what we're trying to do, one of the great things about peptide receptor therapy, PRRT, peptide receptor radionuclide therapy, we're really not good at having short words here, is that you don't have to have cells that are dividing. Traditional chemotherapy needs cells dividing. It's one of the reasons why they used to say this tumour was very chemo-resistant, which it can be, which it is, but it's not resistant to this, because this just sits on the outside of the cell, and then it gets internalised, and then it gives off its radiation, which is very, very short range, which is why when you have your treatment, you're allowed to go home that same day. But the damage happens at a DNA level. And a bit like Tim just described with the crossfire effect, even if not every cell has enough density of these receptors, it doesn't matter because it has a paching effect and it can go to the cells next to it. Even if I have to finish pretty soon, I just want to make the point that when we talk about timelines and when we talk about the new kid on the block, luteate is not the new kid on the block, or is PRRT. So as far back as 1992 is when they started with the first generation, which was indium. And we were lucky enough to be involved nearly 2 decades ago with the earliest generation. But in this gap, patients were heading off to the Peter MacCallum because we didn't have a service here. We started our service in 2011, and those figures I gave you have kind of changed very quickly. We've treated about 150 patients here. So it's very quickly, and the service is getting quite busy. But in along and with that, so again, from the last forum to now, we've got really good proof, knew it anyway, that luteate is better than, say, injections alone. And I won't go into this too long, we can talk about that later. I'll just fast forward this. But the point about this slide is America got onto the bandwagon pretty quickly, and so there is the Food and Drug Administration in America has approved Lutathera. We don't have that approval yet. Again, advocates. So we're fine though, because it's our service is funded in South Australia, so there's not an issue from that point of view. Lutate versus chemo. Should we add chemo? What kind of chemo? How much chemo? How many days of chemo? The ControlNet study has just closed, and I encourage you to go to this wonderful website. Tim's been an integral part of AGIDG for a long time. But although the ControlNet study is now closed, it's in follow-up stage. It's going to answer the question, at least help us know whether or not we should be adding chemotherapy to the lutate and in what sort of dosing. 5 minutes? 2 minutes. So there you go. I was meant to stop then anyway. Multidisciplinary teams, whether you've got a surgeon or an endocrinologist or a medical oncologist or a nuclear med physician looking after you, your cases will be discussed at Tumor Board meetings, often many different times, and that will produce a set of recommendations which they'll go back to you with and say, the team think you should have the following. It could be, you haven't had an FDG PET scan, you need one. We think you need a new biopsy because your last biopsy was 10 years ago. We think you're ready for your next line of treatment. If that next line of treatment is PRRT, you come and visit us at the Queen Elizabeth, and we're working really hard with the telehealth network so that Northern Territory patients that are rural and remote really quite passionate about that, and that could be a whole nother lecture, which was what it was all about at COSA. All coming together to ensure that we work towards making you feel better. And the other big area for anyone that's been a patient, we just keep bombarding you with those quality of life forms, because it's really important, because one of the things about this disease group is you do live for a long time, and that's our aim, and we're going to keep pushing that from years to decades. And during that time, it's not about the tumour burden per se. What's causing you your problems are your symptoms and your quality of life. And so that's how we want to roll on. And that's all I have to say.